you to everybody for joining us today. As Shelley said, I'm Shelley Hughes. I'm an occupational therapist. I'm here with Pearson Clinical Assessment, and as my accent might allude, I'm actually based over in the UK, but I work across North America and many other parts of the world too. And I'm joined by Tina Eichstadt, who's one of our speech and language pathologists within Pearson. And Tina will, I'll pass on to Tina shortly, but I'll just kick off with the first few slides. If you do have any questions, as Sherry said, if you could pop them in the chat, and then we will, whilst Tina and I are presenting, each of us will be attending to questions, and we'll hopefully have time for a few live questions at the end too. So on that note, I'm going to move on to the next slide. So just in terms of disclosures, as we said, we're both product managers with Pearson Clinical Assessment. So the tools we will talk about today are tools that are either published or distributed by ourselves at Pearson Clinical Assessment. We won't talk about any other tools. In terms of agenda, this is just a little outline of what we're going to go through today. So first part is really talking about choosing the right assessment tool for your toolkit. As we said, the title of today's session is about a toolkit for SLPs and OTs, and it's about maximizing, optimizing your toolkit so you've got the right assessments for your needs. So we'll really talk in the first part about choosing and the things that you need to think about when choosing your assessment toolkit. And then we're going to focus on sort of recovery pathways in adults or adult I guess, acute and rehab settings. So the first one, we'll be talking about acute and subacute settings and the sort of considerations you need to think about in those settings with regards to assessment and working with families in different scenarios. Then we'll talk about inpatient rehabilitation pathway and the considerations that might be unique to that scenario, and then home care and outpatient, and again, some of the unique challenges that those different pathways present and opportunities, of course. And then, because it's high on everyone's agenda right now, is remote assessment, telepractice or telehealth. We tend to use the term telepractice in Pearson because we cover education and clinical settings, but I'm aware that a lot of you may well use the term telehealth as well. So we'll talk a little bit about that as well, and just direct you to some resources and tools that might be helpful for you to be aware of. In terms of learning objectives, I've listed these here. We really want you to be able to think about the considerations you need to pay attention to when selecting tools for a given context. So that's the first objective. And then second objective is around describing ways in which an OT, PT, SLP may collaborate when using assessments. The third one, listing considerations when interpreting assessment data and things that you need to be thinking about, and then some of the tools that might be relevant for use in adult recovery pathways. I should also say as well that there is a handout that we put together, and I think the handout was sent out at the top of the hour. That's usually the case. If you haven't got a handout and you want one afterwards, or you haven't received it, then let us know. But I think you should have received one at the beginning of at the top of the hour when this went out. If not, it'll be sent out to you afterwards. So, and on that note, I'm going to pass on to Tina, who's going to kick off the next piece.
Great, thanks, Shelley. Can you hear me okay?
Certainly can.
Thank you. Hello, everyone. My name is Tina Eichstadt, and as Shelley said, we work together here at Clinical Assessment, coming out of our own clinical work previously in our careers into this role on behalf of the professions internal to Pearson. So I'm excited to be here with Shelley and chat a little bit today about working not only within our own professions, but certainly collaboratively across professions. So this next few slides really talks, as Shelley mentioned, about the right tool at the right time, right? So as we think about choosing the right assessment tool, it's sort of a matrix, and I use, I must be talking about my age right now, or dating me a little bit when I bring up the Rubik's Cube, because of course this is a great childhood toy for many of us, but not all of us. So the Rubik's Cube really represents for me the idea of really a matrixed approach, or a kind of a puzzle approach to looking at how we choose assessment tools at the right time for the right context. So that whole notion of tool choice has really resonated with me over the years, because so many things go into when I get a request for an assessment, or I begin an assessment process. What are the considerations that I take into account when I'm making that tool choice decision? Obviously, we've talked a little bit about care paths, where we are in that recovery process, particularly in healthcare, but also these other dimensions of diagnostic scenario. What do we know about that patient coming in, or that client? And how are we thinking about the diagnosis as it stands today as I walk into that assessment? Or do I not know, and I'm making some broad assessment choices because I'm trying to ferret out what that diagnosis is? And then certainly the clinical workflow. Where are we in considering what kind of assessment I want right now? Do I want a screening tool? Do I want a comprehensive assessment, or a sort of an overview assessment? Am I looking at intervention tools that either will lead from the assessment or follow on in my recommendations? What am I going to do for progress monitoring? So all of these different dimensions, if you will, play into our minds as we're thinking about tool choice. And certainly we all have our favorite tools that we use clinically. I know the ones that I used when I was working at the hospital. I did work acute care and subacute and outpatient for a number of years. And so as I was thinking about that, certainly I would want to go back to my favorite tools because of the value that they provide in my decision making, but also then to check myself going forward, and to make sure that I'm also not only communicating with colleagues like Shelley and my OT colleagues, but also really thinking about when my favorite tool might not be the best tool for me. So this puzzle that we try to solve is really quite important. One of the things that several of the things that we think about as we think about tool choice is this notion of working at the top of your license. I first heard this phrase, I don't know, maybe 2016-ish. I was at an ASHA convention, and I was at a ASHA Foundation breakfast, and Alex Johnson had been giving the keynote and was talking about this notion of working at the top of our license, which basically means that this kind of decision-making requires the highest degree that we have. In this case, for most of us, a master's degree. Some of us will have PhDs, of course. And as we think about working at the top of that licensure requirement, this is where this decision-making is really critical. As we think about assessment tools that we use wherever we are in any of those dimensions, we need to be using the best of what we've been trained to do to make those tool choices at a given time for a given patient or client in that context. So of course, as experts that we are in assessment and in these clinical conditions that we serve with patients and or families, we use that expert case review. We do good planning. We take the time to do good planning in tool choice. And if we have a chance to observe the patient before we make those tool choices, which isn't always the case, but occasionally, especially in acute care, you can use that behavioral observation to narrow down the most important tools and assessment tasks given the time that you have available to you, which we know is a huge constraint. Obviously, we want to do this tool choice work at the top of our license based on all of these things that we can do in our selection with the efficient use of institutional resources. So we're going to talk about in this webinar a little bit. Shelley and I are going to do some vignettes, some storytelling, if you will, from previous clinical days, but I'm sure you'll all have some as well in your minds. Think about how we collaborate to use resources from the institution efficiently and certainly collaboratively so that we can carry our places on the team as well. So all of this tool choice work isn't just I have to go grab something off the shelf or I have to pull it up on my computer. It really is this high-level clinical process that's part of our evidence-based practice, that's part of our teamwork, that's part of this day-to-day assessment work that we do. And we just think it's really important to consider as we go ahead. Let me just say a couple more things, and I'll turn it back to Shelley on interprofessional practice and toolkits. So lots of questions to consider, I think, for us clinically in our day-to-day work about where can tools overlap and where should they overlap. So as I'm thinking about different kinds of assessment, that just makes our puzzle, or our Rubik's Cube, if you will, that much more complex, certainly. But it's important to consider where those tools should overlap. Should I be doing the same cognitive assessment? Probably both of us don't need to give the same tool between OTs and SLPs, and often we don't, but we use the same tools. And so to collaborate on those is really critical. In addition to what kind of cognitive skills are we going to assess? If Shelley does one kind of cognitive skill assessment and I do another, what is the benefit or the redundancy of that overlap? And so there's interesting conversations at play among team members with the reduced set of time that we have, with reduced resources. How might we strategically work together on our interprofessional teams to choose the right toolkit for the right patient at the right time for the right outcomes? And all of those things are critical in our tool choice. So there are reasons probably that you can already think of. We'll talk more about this in the care pathways section here, where you might assess the same constructs with different tools by different professionals. Certainly, we're going to have a slightly different frame perhaps on how we think about that. But what's the value of making those strategic choices either direction? And then consider where overlap can be good. We know that multiple measures in a construct is best practice. So when we can measure cognition in one way, measuring it with a second tool is value added, because no one measurement tool gives you everything that you need. So as we think about that, that's certainly a reason for overlap in construct measurement, but then also measurements of different kinds. So tasks sometimes, so we can get a norm that we can compare to a larger population for that kind of patient or client. But we're also going to want to do informal tools. Where does dynamic assessment fit in? Where does this particular kind of task or assessment process fit in for this patient because of where they're going to go next in transition to a different phase, to home, back to work, etc. So all of those things impact our tool choice for the toolkits. Shelley, I'm going to hand it back to you for a little bit more on this topic of tool choice.
Wonderful. Thank you, Tina. So we really just wanted to lay out a few of the important considerations that you have to think about upfront before you're even getting into the weeds, working with assessments in more detail. So some of them are listed here, and I'll just kind of talk through some of these points. But really, in terms of administration time, it really is important to consider at the different phases, the different pathways, what can the patient, the client, the individual tolerate. At times there's a need for a very brief assessment, a screening tool, versus other times when lengthier batteries can be tolerated, when an individual is able to tolerate something that's a little bit more in depth. And it really is a skill, really, to strike that right balance between getting the optimum administration time and the optimum information that you can get from that session. So this is why we need a toolkit, because of all these things that we need to consider. In terms of language, what language is the assessment or the tool developed in? Usually for North America, we're talking about English, Spanish. Perhaps in Canada, we'll be thinking about French Canadian as well. But there are other tools available in other languages as well. But if you are using an assessment, it really is important to use it in the language for which it was developed. If you are using interpreters, then it may not be appropriate to use a standardized tool. And I would also caution against using family members as interpreters, because they, whether intentionally or unintentionally, they can bias the sessions. So I think it's really important to think about the language and whether a standardized tool is appropriate for an administration. In terms of administration options, we often talk about digital versus non-digital, or digital versus paper and pencil. And there are things to consider here, like paper and pencil may take time to score and interpret. It's a lot lengthier, whereas digital can be much quicker. You can score on the fly. But some questionnaire type tools lend themselves very easily to be administered via digital digital means. You can email out a questionnaire to an individual or a caregiver, and it comes back to you ready scored. It reduces the burden on your time and on other people's time as well. So, that's often just something to think about. In terms of scoring and reporting options, scoring by hand is often the most, prevalent method of scoring, but more and more people are turning to digital scoring options, and that reduces things like the opportunity for error creeping in, scoring error to creep in, but it also provides opportunities for report writing options. So a lot of the digital reports now, they score the assessment for you. They will perhaps have a narrative report, or they allow you to quickly generate a report that you can extract into your electronic health record system, or you can combine with another report. You can edit the information and bring it into another report. And it also allows you quite often to be able to monitor repeated assessments. So if you're using the same tool over and over again, you get to build a database of information on that individual. So you can actually track and create profiles of progress and change over time. In terms of progress monitoring, that's very important and obviously becoming more widely used. And I think that ties in with my last point, that as digital options become more readily available, then that's something that is much more prevalent and easier to support in your practice. And if an assessment is done early enough, you can actually get a baseline assessment and then use that to build on through repeated assessments. So I think it kind of ties in nicely with the last point. It's obviously important to think about the psychometric data around an assessment. So you need to understand things like reliability, validity, classification accuracy, and things like that. Is the test providing the information you need? Are you using the right tool for the job? And there might be different reasons you would have different tools in different scenarios. And then thinking about whether something's public domain, homegrown, or published. One of the most important considerations here is whether something has normative data. Has it been validated on the population for which it's intended? So, and there's a place for all of these in different situations. So it's not saying one is better than the other, but it's just saying that these are some of the considerations that you need to take into account. And then finally, there are different scales that use different respondents. So you can have something that may be a self-report scale, a self-report rating scale. And that is really useful for really gathering information on an individual's own lived experience, their internal experience. But ideally, it would be combined with perhaps an observational or performance-based tool, because they provide more objective data. So getting that lived experience alongside objective data it's very powerful in helping you build the picture and helping you plan for the next stages of the pathway and next stages of recovery. And I think it's also really important. I think these are really important points on your screen here. Just 4 simple points, but really a score on a test doesn't prove or disprove anything. It just gives an estimate of performance in that particular area of behaviour in that particular point in time. And it really must be interpreted in the wider context of results from a range of tests. So you shouldn't interpret a test data on its own and in its entirety on its own. You really have to consider all the other factors that perhaps have influenced that assessment session and other factors from other assessment sessions as well. And you should take into account previous abilities and achievements. For example, if somebody scores perhaps within normal limits on a particular assessment, well, we have to think, would that be how that individual would have been typically, perhaps pre-morbidly? Would they have scored within normal limits? Perhaps they would have scored extremely high. So it represents a change, and it's really important to think about, how does this represent this individual's journey and this individual over the course of time. And then really just to say, this is why you do need a toolkit. There is not one size fits all with assessments. You pick and choose and use them based on what you know and what you don't know. It is really a process of hypothesis testing. You know, you use an assessment to back up what you're seeing and what you need to know, and often you're choosing an assessment or a tool to test a hypothesis, and you may have to go back and retest with something else. Once you find out a little bit of information, you may well need to dig a little bit deeper and find information using another tool. And they're there, as I said, to back up your clinical observations. It's not there to make all the decisions for you. It's to back you up and to give you some data and information to help inform your decisions, and really give yourself and your team some flexibility. You know, as I said, there isn't one size fits all. It is about being able to pick and choose and make sure you have the right tool at the right time, and being flexible as a team around which tools that you use and have available within your service. So I'm going to talk on now about the recovery pathways. So this was, I guess, point 2 in our agenda. And we're just going to talk through some applications of a toolkit and some of the things that you need to consider in different scenarios. So first of all, we're going to talk about acute and subacute care, I guess, or the subacute care pathway or recovery pathway. And really, this phase is a really, really important phase. You're often working here to capture information from family members. We're working with individuals who perhaps have very low tolerance levels in the beginning, but very rapidly changing tolerance levels as well. And the information we're looking to capture may well change on a day-to-day basis. Because recovery and change in the individual may well be so rapid. And at this point, we're really thinking about how can we collaborate with the family and optimize our time with that individual. It might be that a patient or a client can only tolerate 5 minutes of interaction at a time, but you may expect rapid change, so that's quickly changing over the course of a few days or a week. So I think it's really important to think about, in your 30 minutes that you might have with this patient or a family on any given day, how do we use that 30 minutes to the optimum to optimize our time? Could we use perhaps 15 minutes on an eval and 15 minutes working with the family, perhaps preparing them for the journey that may be ahead of them, or perhaps gathering information or educating them about some of the changes and some of the things that are happening. And it really is important at this stage to consider the capacity of the family and how you work with them on that journey, and work with them to think about the next phases, think about medium and long-term planning. And so I think this phase is not just about working with that individual, it's about getting all these things right as well. And in terms of examples of tools that you might think about at this stage, early on, bedside forms provide very high power and level of involvement for patient and family. So you can use these to get quick measures, quick pieces of information that can help inform your next, I guess, your decisions and inform the journey that you're about to go on. We've mentioned here about clock drawing. So there's an assessment called the CLQT Plus, or the Cognitive Linguistic Quick Test, has a clock drawing task within it. Clock drawing is a really, really good quick task that you can do daily. You can use it to observe progression and certainly to inform very early on whether there's perhaps cognitive change, cognitive impairment, and how that might be changing on a day-to-day basis. In terms of aphasia, something like the WAB R might be a tool if you are working with an individual who is presenting with aphasia, and there's a quick bedside screen that you could use, bedside version of that, and you could perhaps look at doing that on day 2 and day 5 and see see the change, monitor the change over the course of those days. There are also patient-reported outcome measures, and there's one I've mentioned here on the screen called AM-PAC, which is the acute measure of post-acute care. And this is a quick 6-item, well, there's different versions of this actually. The most popular one is the 6 clicks, but there are different versions. So there's a version that goes from very high level of need, perhaps working with patients in intensive care, through to working with patients out in the home and the community. And it is a quick patient-reported outcome measure where you're just monitoring change over the course of time. So it looks at mobility, self-care, and cognition. So this can be a tool that complements some of the standardized tools that you may well use as you're going along. And then something like the BCSE, the Brief Cognitive Status Exam, is a very quick status eval which can be used bedside as well, just to get information in these early stages. So there's sort of some of the tools that you might be picking and choosing from in that acute phase of care. I'm going to pass on to Tina to talk a little bit about, some of the clinical conditions that we might think about within that acute care as well. So I'll pass on to Tina for the next part.
Yeah, thanks, Shelley. This sort of second half of each of these care pathway events. So here we're in acute and subacute. Now we want to sort of transition this idea of tool choice into some of the vignettes that you all have in your mind, I'm sure, as you're thinking about your current practice. One of the reasons I loved working acute care back in the day was not just the intensity, but the dynamic nature of the days, right? Everything is sort of as it happens, as it can happen throughout the days. And I think as we look at the clinical conditions and the way that acute care works, we think about tool choice as dynamically as the days are for us in that kind of clinical practice. So broadly, we're looking at a lot of different constructs that aren't really profession specific. Certainly we're looking at the impact of language impairments, what's happening, and that affects everything that is happening with that patient and family. Visual field deficits that come along, what's the cognitive status of this particular patient at this time? What kind of cognitive status can we expect in the next hours or days as they're with us? And whether it's dementia or some other sudden onset cognitive changes, if it's dementia, of course, they're usually in acute care for a different reason, but not always. And so as we're thinking about cognitive status, that context for tool choice is, of course, important in assessment. But my mentor and one of the master clinicians that I worked with in acute care would always tell me, oftentimes if we're looking at cognitive linguistic issues, some of these other core clinical constructs, usually our first bid is with feeding and swallowing. So obviously, as we're looking at this totality of assessment needs and tool choices, often the referral comes to us first is through that feeding and swallowing channel. And so as we think about that, we're fitting in sort of dynamically. If we're going in for a bedside swallowing eval, what else are we going to gather informally or maybe formally during that bedside eval for swallowing? Or if we're on our way to video fluoroscopy, or if we're on our way to a different, more comprehensive swallowing assessment, fees or what have you, we're really looking at what other tools can I fit into that construct that tells me more about this patient's capacity for safe swallowing. And their communication around food choices and, the mealtime in general. And so that really is an opportunity for us to say, it's not just about the swallow. It's not just about the food safely to the mouth or how our arms are working. It's very much that opportunity in acute care to drive the assessment tool choice from creative, collaborative ways of putting those tools together based on the referral that we're given. So we clearly have a role to play as SLPs and OTs in supporting those, but think about the patients, those of you that are in acute care or subacute care, think about the patients that you see and think about that referral that comes PT, OT, SLP, eval, and treat, right? So think about as they come, how you might consider tool choice among your team as a key factor in those early days of assessment. And how can we be so adept at moving through our tools to get the most information in the least amount of time when we only have 5 or 10 minutes at bedside. And so that really leads into some assessment practices that are really collaborative opportunities for you and your team to brainstorm, as Shelley and I remember doing and did for the preparation for this, is to think about how we might use assessment practices in acute care and subacute in those ways to get the most information in the least amount of time. So certainly, Shelley alluded to this earlier, to just check in after that referral comes in and say, okay, Shelley, I'm going to grab 10 minutes now because it's lunchtime. We're going to go in and take a look. Do you want to come with me, or do you want to grab the family while I have the patient? And we'll do different assessments to get at these root causes of what we've read in the chart. So as we think about that kind of collaborative practice, it's so wonderful when you've done it and you've seen it every day to just push that another step forward in your assessment practices. How might we get into a rhythm between SLPs and OTs in particular to grab what we need? I'll do lunch if you do breakfast. And if you do breakfast, can you focus on this? Because I'm still not sure yet from the assessment that I've already done what's happening with their cognitive load while they're eating. Or Shelley might say to me, you know, really, we're looking at this kind of motoric upper limb kind of movement, and I need you to do this while you're working on and watching their swallow. So all of that assessment may be backed up by a quick bedside of the Western aphasia battery, or a clock drawing task, or meeting with family about premorbid status. But all of those things can happen as we really push our assessment into that next phase of sophistication, of collaboration, of dealing with the constraints of the day in healthcare. These are just some of the things that we think about, and it makes our tool choice considerations perhaps different on a different moment. Shelley, do you have other thoughts before we transition out of acute care?
The only other thing I was going to add is that often at this point we're thinking about environmental adaptations and accommodations that we may make as well. So again, working closely in partnership with our SLP colleagues, then we can help determine perhaps are there other factors influencing, perhaps that feeding, swallowing intervention that is happening, and we can inform each other's interventions by informing each other about our findings and what we've learned along the way. So I think that would be the only other thing I would add. It's such a privilege to be able to work interprofessionally and practice in that way, and I think it's really important. So
yeah, and as we transition, before we go, Shelley, I just thought that we could take a second and see if people have similar practices or ideas in tool choice that they want to share through the chat, that we could gather and maybe offer to the larger group some of these other strategies that people are using for that collaborative assessment practice in acute care. If you have any thoughts, just chime in, and if we don't do them right now, we can do them more at the end in the Q&A time. But I think it's great to be able to share amongst the group here today, practices that you're doing today in clinical practice that are making your assessments that much more powerful, that much more impactful to families and considerations. Feel free to chime in, and we'll highlight some of those a little later.
Wonderful. Thank you, Tina. Right, I'll move on to the next slide then, as we just give people a second in case anybody's typing in, and I'll just go slowly to the next slide to give them a chance. Okay. So let's talk a little bit about the rehab setting. And I guess, you know, this is another care or recovery pathway or journey that you will all likely be on with patients at different times. And this really is, you know, the needs here change from being obviously more acute to medium to long-term planning. So there really is more of a focus here on the specifics of issues. So, for example, in the early stages, you may be looking at you kind of having an overview, you're screening for issues, perhaps you're doing some assessments that are starting to identify maybe there's some memory problems. Maybe there's some executive function challenges. Maybe there's some sensory processing or some motor challenges. And at this stage, in the rehab stage, we can really start to think more about the specifics and really sort of get into the weeds a little bit more with our understanding of the individuals we're working with. And at this point, it is where we start to look at full batteries rather than the quick assessments and the quick bedside type assessments. It really is here we start to think about the full batteries we use to perhaps profile needs. And we're starting to think about tolerance and stamina. Individuals, for younger working age individuals, we may be starting to think about getting back to work, or what they need to think about to be planning to be getting back to work. So this is the first stage we start to think about those things. And we need to know whether assessments are robust enough to understand what's required to get back to everyday life. An assessment can be a really useful tool to give an individual that aha moment about what they're struggling with. In a clinical setting or in a non-challenging environment, it's not necessarily always apparent where the needs may lie. And sometimes an assessment can really help pick apart and just show that individual, or help them understand where some of their needs are, and more importantly, where their strengths are and where they can focus and use those strengths. So an assessment is really good for sort of highlighting that. And at this stage, we're really also starting to think about the potential for planning compensatory strategies. Are these things that we need to be thinking about? And can an assessment, if you use an assessment dynamically, you can use it to help you identify where compensatory strategies may be useful and may have potential for application. And we have to, if we're working with working age individuals, we can help work through that workday. Where can the therapy team support them in that workday? Where may they need communication, speech and language support? Where may they need physical supports, maybe adaptations or just prompts and tools around them? So we really are thinking about supporting the patient and the family, and using the right tools during this phase can really help us pick apart where those supports are needed. So if I'll just move on to the next slide on this. So in terms of assessments, you'll see, again, some of the same assessments that we perhaps used in the acute and the subacute phase. But we're moving along in the journey here. So as I mentioned before, patient-reported outcome measures. So again, the AM-PAC can be used across the whole journey, and there's different forms for different parts of that journey. The CLQT Plus, we may at this point be thinking about using it in its entirety, perhaps using the full battery and being able to profile somebody's needs across the various areas that the CLQT Plus covers. And there's an aphasia administration, or there's the traditional administration of that. So it can be used for different requirements. We might want to look at the WAB R again, the Western Aphasia Battery, and this time we can think about the full battery rather than the bedside version to get a much more in-depth profile of needs. We can start thinking about ADL assessments and something like the Texas Functional Living Scales, which will help profile some of those ADL needs. Some of the ADL assessments are really good at sort of picking perhaps some of the instrumental activities of daily living that may not be so apparent up until now, and these start to become apparent at this phase. Obviously, personal activities of daily living are, I guess, not, I can't think of the word I'm trying to say, perhaps not so sensitive to certain needs, whereas some of the instrumental activities of daily living can be more sensitive to sort of mild cognitive impairment, for example. Then we might want to think about motor skills and motor ability. So the BMAT, which is the Bruning's Motor Abilities Test, looks at motor skills, mobility, strength, tolerance, stamina, and that can really help with supporting placement decisions and helping think about that part of someone's journey and where they may need a different living scenarios. Driving assessment, as I've said, some assessments can be really useful just to help highlight some of the challenges that an individual has and help think about, well, do they need to be referred for a full driving assessment? Do we need to get those certified driving rehab specialists involved? And sometimes they can help provide the insight for an individual to help them realize that they actually do need, they would benefit from more support in that area. So again, it's about that aha moment of realization and helping perhaps challenge and understand those needs. And then we can also start to think about other tools. So you'll notice I've mentioned something on here called RehaCom, and that's a computer-based intervention package, which can be done in clinic, in hospital, or remotely by a patient at home. And there's different, I guess, packages, different tools within that to help provide rehabilitation sort of scenarios and strategies. So it is all computer based, and it may look at things like memory or executive function and things, but that can all be set up and I guess set up to the patient's needs. So you can sort of pick the tools based on that individual's needs. So we can really start thinking about higher level rehabilitation at this stage. One thing I should mention, and I probably should have mentioned it earlier, in the when you get your handouts, your PDF handouts for this, at the end of it, there is an appendix of assessments which will provide a summary of some of these tools that I mentioned, so you can kind of refer back to them. But also you can find them quite easily on our website as well. So, but I imagine some people will be curious about some of these. So, on that, I'm going to pass you back to Tina, and I don't know, Tina, I noticed some people have put some comments in from the question before. I don't know if we want to touch on those or save some of those till the end.
Yeah, no, I wanted to highlight one here from Sherry, who commented, I use a Google Doc that I share with the OT and PT, and we each go in and put in what we did and what info was obtained so that nobody redoes something and no time is wasted and we all see the results that were gained. That's a great suggestion of a common document that you can input into. Back when I was in acute care, we were using paper charting still and a little bit into digital charting, but certainly a common place that you can add assessment information. You can watch your teammates as they put in data and track your toolkit plan for that particular day or phase of recovery or what have you, but great suggestion by Sherry. Those common tools, those ways of working that allow us to share data and make those strategic toolkit plans are so critical to really leveling up our clinical practice and our interprofessional clinical practice as well. In rehab, let's just talk a little bit about these clinical conditions and considerations and these assessment practices collaboratively. It's not so much about the diagnosis in some of these toolkit considerations as it is about where we're going next. So if this particular patient or family or scenario, clinical scenario, has this goal in mind, that really is what should be driving the assessment toolkit that you do. Certainly, if we had all the time in the world and if we had all of the tools in the world that we wanted to, we could assess and assess and assess, right? But sometimes it's not about the assessment. It's not about getting in all of those tasks that you wanted to, formal, informal, what have you. It's really where we're going next. Like, what's the outcome, that the reason this particular patient or client is here with us? And so when we think about it in that way, our tool choices, I think, become a little different. And so as we think about that patient skill or the construct domains, our assessment plans, as we build them strategically and collaboratively, the question really comes, what are the priorities of the patient and family? And the reason for being in rehab in this case. And maybe not so much about cognitive status, attention status, memory, all of the different pieces of memory that we could do, all of the different types of attention we could measure. What is going to be required when this patient or client leaves us? This is the example that Shelley and I had for this part of the care pathway. Just briefly, a 22-year-old patient, consider post-TBI, now in rehab, really looking at going back to school to finish a college degree or some kind of a degree, but also in this particular case, this patient in our experience had a job that was also he was attending that was a very particular job. And once we learned about this job and what he hoped to get back to, as well as finishing his college degree, you know, we really changed our assessment practice sort of on its head. So in this particular case, this gentleman had a technology job where his role was to spend 8 hours a day in a clean room reviewing sheets of floppy drive holders, if you will. I don't even know what they were exactly, but there was a sheet of about 50 small technology parts that he had to use a magnifying glass and scan for 8 hours a day, and make sure that they were not flawed in some way. So never mind, after his head injury, the attention memory issues that he had that were resolving, but slowly. But he also had huge visual field deficits. He already had prisms put into his glasses. He was really struggling with fatigue, mentally, eye strain, headaches, things like that. And so that job site visit that we did collectively as a team, and then be able to come back and make recommendations for, we need to assess these 3 things because, oh my goodness, if he's going to go back to that job, he needs to be able to do these very well as part of his own awareness training, as a part of his family's awareness training. All of that mattered because of where we were going next, or where we hoped to go next, and how might we reduce the workday, and how might we reduce the load on these skills that we're still recovering from his injury. All of those clinical conditions matter as we think about our tool choice for assessment. So if we think about collaborative practices, certainly involving the patient and family in those assessment choices and why we're doing this, but with, you know, the tolerance of rehab that you have to have. What kind of independent practice are you putting into his workday so that he can continue to work on those skills when he's not with one of you in therapy? And then also in that ongoing assessment of how much progress are we making so we can help the family make plans and help him make plans as an adult for when he leaves us. Expectations to his employer, expectations to his college class, you know, instructors and his supervisor and what have you. All of those things play into that practice. Shelley, let's move on with the last section, if you will, just for the sake of time.
Absolutely. Thanks, Tina. So the last section is around home care and outpatients. So again, here we're thinking about individuals that may be much further down along on their journey, but it may be people that have long-term conditions, perhaps even degenerative conditions. So they're starting a journey in a very different way. So there's lots of considerations here that we need to think about in these scenarios. You know, we're often thinking around long-term placement implementation. So some of those decisions we've made during the rehab phase, we may be thinking about implementing those recommendations. We're thinking about the family accommodating to long-term change and the individual accommodating to long-term change. So, you know, these aren't necessarily tools that are going to help it. We don't need assessment tools to help us with some of these things, but some of the tools that we've used earlier on could really have potentially helped us plan for this stage of a journey. But we're also potentially looking at increasing independence. Perhaps we've used tools that we've used for progress monitoring, and we can really see change over time. And we're looking at increasing independence, and we can really show that. And also, we might be looking at vocational rehabilitation, you know, really getting somebody back to work if they're of working age, looking at phase transitions back to work, looking at workplace accommodations and things. And one of the other things that I wanted to sort of mention is often, if we're doing repeated assessments, sometimes it can be really frustrating for the individual to see progress and to see change. And sometimes an assessment can be a really useful way of just showing them how much they've progressed along a journey. So it's not necessarily just about you getting information. It's actually can be a really positive thing for the individual to see their change and their journey, and especially at times when they perhaps morale might be low or something, and it can be a real boost to somebody to show that change and progression over time. In terms of some of the examples of tools, I think the first point here just leads to the point I was just making around progress monitoring, repeating earlier assessments. So for example, the R bands, which is another assessment that I haven't mentioned yet, which is an assessment of neuropsychological status. That has different versions, which allows for repeated administration whilst eliminating any practice effects. So, at this phase, you may be doing or administering an assessment, having done it repeated times, but it can be, as I said, a useful tool for you to monitor change over time. Again, the AM-PAC, you've seen this mentioned on every single one of these areas, and because it can be used from across that entire journey, and there are outpatient forms which you can use in this scenario. The ADLs, again, are really important just to keep a check on, especially for longer term conditions. So again, Texas Functional Living Scales, which will help look at those instrumental activities of daily living, and can be good indicators of cognitive decline. If you're working with a long-term condition that may be at risk of cognitive decline, it can be used in the early stages of looking at dementia, for example. And then higher level cognitive assessments. So some of the ones mentioned here, the CLQT, the R bands again, and the BADS, which is a dysexecutive behavioral assessment of dysexecutive syndrome. These can be really useful for helping pinpoint some of those higher level needs for supporting somebody in the community. And again, memory assessments, so the RIVME behavioral memory test can be a really useful tool for profiling some of the memory needs, profiling where someone might need supports within their everyday environment. And then there are rehabilitation tools as well, again, like RehaCom, which will help with computer-based or home-based intervention and help you track and monitor and continue to provide that intervention in a home setting. So it doesn't have to be done in a clinic, and you can still continue to monitor it and implement that intervention. So I quickly ran through those because I know we've only got 7 minutes left, and I'm going to let Tina move on to the next couple of slides. But if you have any questions, now's a good time to start thinking about popping those in the chat.
Great, thanks, Shelley. So just briefly then, as we think about home care and outpatient tool choice and putting kits together, really, of course, at this point, we're thinking about also scaffolding the environment for success, plus transitioning to whatever the next stage of care would be, or no care at all. So collaboratively, we're thinking about a number of things in home care and outpatient status that we do as a team. Even if we're not all directly treating that patient, we're still on a team that we can use together and think about what kind of tools we need to do to help set up those scaffolds or help train those communication partners. The TIFLs is a great example, as Shelley mentioned. If dementia is in early stages and we're looking at scaffolding that environment around somebody who's still at home, and really working with their caregivers. If I know check writing is hard, I did the Western aphasia battery maybe earlier on in the care path, and I know that writing is difficult from a language standpoint from some of those supplemental tasks. Shelley may have done the TIFLs to say, yep, in fact, check writing is hard. Then it becomes one of us that can do the caregiver conversation around, okay, how are we going to support this from a communication standpoint, give as much independence as we can, if this person was the check writer in the household, down to how we might support that for accuracy, for safety, for all the things that caregiver may need. So all of those kinds of things, adaptations, compensatory strategies, those communication partners and social networks, really their focus is on making sure we're participating in life. Those of you that are in the aphasia world know that the life participation approach to aphasia really helps us focus on those patient, family, caregiver outcomes. And our assessment toolkits are not separated from that. They're very much integrated into that space of how do we have this person, this client or patient continue to participate as much as possible or in new ways in the life that they're leading beyond us as professionals. So all of those things really come into play in the home care outpatient, and our toolkit for assessment is driven by the needs of that collaborative practice and that collaborative care for the outcome that's desired by the patient and family. So much we could talk about those. I know that there are a couple of questions in the chat, and really they center in this case around telepractice, which is perfect because I did want to talk a little bit about that before we go today, because it's so in our contexts in this day-to-day world that we're in, and in tool choice and in toolkit development, this is front and center in terms of conversation. So whether you're doing in-person assessment or you're doing remote assessment, I would really direct you to this link on our homepage. It's pearsonassessments.com/telepractice, which talks about the totality of sort of COVID-related issues. If you're doing in-person assessment with PPE, we have a new document that starts to help you ferret out the issues related to delivering assessment tasks using PPE and some of the considerations we would recommend. If you're doing remote assessment, most of our tests online are on that landing page. You can search by test and see where we have guidance documents for those remote assessments. Many of our assessments can be done remotely with modifications in some ways. There's certainly studies out there for many of the adult tasks that are done across tests, and so you can use those guidance documents to help you make those decisions about remote assessment. And I would really recommend you look at some of these resources that we have about norms versus equivalence. We're really in the position of looking at equivalence rather than norming of these assessment tasks because of what the standards for psychological assessments require. We're really talking about a mode change, not really a requirement for new norms. So we need to establish equivalence between those modes of in-person and remote. We talk a little bit, we have a document on our website about the use of facilitators, disinfecting test materials, and how you might do that and think about that. And then both Shelley and I and Nancy Castilleja, my SLP colleague, and I have been doing a series of office hours for telepractice and COVID-related issues, PPE and otherwise, for the assessment context. So as you have questions about all of those related issues in your toolkit choice across the continuum of care, across professions, we really have tried to do a lot of work to support those needs in the last 4 months, and we'd encourage you to use this landing page to support all of the questions you have around how to do assessment, not just clinical tool choice, but also about other things. So we have about a minute left, and I'm looking at the question box and wondering if anyone has any last minute questions. We answered the one about use for telepractice for sure. Let me just take a quick.
There was just, Tina, there was just a question around RehaCom and around the evidence base for that. And I did send the person a link to that in case you haven't seen it. There was a link to the research on our website around RehaCom. So I've just sent that off, but I haven't seen any others.
Well, we do want to thank you all for your time today. Our presentation is just about ending. So if you are in Canada and you want to look at the Canadian website, great. Otherwise, thanks so much for your time today. I think we're out of time.
Thank you, everybody.